All right. Can everyone see this okay? Good. All right. So welcome to Blockheads round something. Today I get to talk to y'all and kind of lead this discussion. It's about block training, for which I'm, very excited. I think this is a fun topic with a lot of, kind of interesting points. So, and you kind of do that traditional kind of more discussion format. So I kind of want to just go through some things here. So I always kind of think about this when you have, I think everyone has some of these faculty where you hear that they did a block with some of the residents that aren't the strongest. And you just kind of imagine how that block goes in there. So how do we improve everyone's training to get us in a better spot? So, we have a better block success rate. And, kind of looking now where we are, I just feel like, the resident and students' attention spans are absolutely nothing. So how do we navigate that and, get them comfortable with their knowledge, their acquisition, and get them to do successful blocks? So some kind of interesting points. So I would start off with kind of going through, kind of seeing what everyone thoughts about, kind of the lecture standpoint. Ours has kind of evolved a lot, we mainly because of that whole attention span thing. So when we first started kind of teaching blocks, we kind of would do this ridiculously long lecture, and then we would just then go to like a scanning format, and everyone forgot what blocks they covered, and it just really didn't work well. So we kind of switched a lot more to kind of, we do like a block or two and then immediately do that, just scan that block and kind of review the anatomy. And we've kind of, gone to that kind of lecture scan kind of kind of model. And I was kind of just curious to see, what y'all are doing, how you're kind of approaching this when you have a, a conference block, what you've kind of found that has worked well for you. Because we've kind of found that, kind of breaking it up more and kind of getting people moving kind of kept people a lot more awake and engaged, kind of immediately jump from the content to the scanning.
So we did the same thing and kind of had the same results, as in we did these biannual massive stems where, there was an hour and a half lecture and then we go through 20 blocks all at once and everybody would promptly forget everything within a week. And so we split it up into 5 sim sessions once a month. So I recorded asynchronous curriculum, 5-minute videos, very similar to what Jalen Avila does. And we just pretty much put a 5-minute video on femoral fascial lealca and pang. And then that is what they watch, within a week prior to the sim. And then in the sim, the small groups spend an hour just going through those 3 blocks. And we go through cases, and then we do that once a month. And the retention rate has been amazing. So I actually find that at the end of the year, my interns are blocking independently, which has never happened before. And we surveyed them too, because why not? They're our guinea pigs. So it works a lot better. In some of the conferences, you really have no option, right? Because in courses like Nysora or ASVAB, which are wonderful courses, but you have no choice but to spend an entire morning on the upper extremity and then you scan and whatnot. But I'm not sure if there's an answer as to how to break that down a little bit better.
Yeah, that sounds great.
Yeah, I think you're sorry. I think you're right on this. I think it's short teaching bursts is how we kind of learn. I think it's really hard to do. I think it's painful. I don't want to give a all-day block course or sit into an all-day block course. So I think these short, very simple teaching tools are kind of the way to go. And that's how I think most people learn.
One thing that helped us too is we created on-shift procedure guides to help with this, and so the residents can quickly reference like, this is how we want to have it done. This is our protocol here. Little QR codes link towards like a lot of the local anesthetic dosing calculators. So that's really helped. And then we have these monthly sims called Super Tuesdays, and so we repetitively do sim 4 times a year with the having a dedicated ultrasound day. And we'll implement a block into that so that they're getting repetition throughout the year. And then they'll all have one lecture where we go through just the basics and the safety of nerve blocks. And I found that just doing that 1 hour, but then the rest of the time is just repetition with their hands and doing sim. I think they've appreciated that a lot more versus just doing a kind of a 5-hour didactic session.
Yeah, we do the asynchronous thing too, where we have the 5-minute videos beforehand, and every 4 weeks we have a kind of like procedure lab where we teach the nurses how to do peripheral IVs, we teach the residents how to do blocks and IVs, and then the advanced rotators we have really focusing on the blocks, and we use meat models as our primary needle skills technique. But one thing that I'm hearing from you guys that we don't do is that we don't do on-person scanning during those sessions to show the actual anatomy, which I'm wondering if that's something that we're missing.
Yeah, I think our residents kind of really, kind of really solidifies everything to kind of see the anatomy kind of right after that kind of teaching. I think that's pretty helpful. One other thing that we've kind of done is we started, kind of incorporating a lot more gamification when we can. So we have, some, internal sono games where we have, putting 3D puzzles together with different blocks and, kind of just making, different games kind of force people to recall content. So that's been kind of, the gamification has been another kind of, adjunct to this kind of, traditional kind of lecture style. Has anyone kind of made a decision on time? Like, it sounds like a lot of you all doing like 5-minute videos. Has anyone kind of made any other kind of moves in terms of locking down a certain like lecture to scanning ratio that you, employ or anything like that? I don't know if there's a perfect recipe.
But we don't really, we don't really use like time as the end endpoint. We usually more like I watch them do it, and if they reach some level of like they can do it without me touching their hands or correcting them, at that point I'm like, okay, you can move on to something else now.
One time I was teaching a course that worked really well was I had a live model, and then I had a gel phantom, and I would make them show me needling and then show me the location, point where they would go, then go back to the needle and try to attempt to, it was this back and forth. I don't know if it was great or not, but it seemed like it gave them, because the meat models are great. I love the fact that you guys are, it's so much work and they're so gross. I know people have done some amazing work. I give you guys credit because I'm just like, oh God, a meat model. And I feel bad saying that. I just don't want to do it. Like, I wish there's a company out there at Astra that I saw that did simulators. I don't know if you were with me, Dan. Remember they had decent simulators. I don't know the name of it. It was a British company. I think it was like was that right,
Valkyrie?
Dan? I don't know.
Was it Valkyrie?
Yeah, they're painful, right? Like, I want something that you can open a fascial plane, but then it goes away and I don't have to keep doing it again. And the meat models are great. It's a lot of work. So I think for me, the residents really just needle visualization and then the anatomy, needle visualization, anatomy, needle visualization, anatomy. I think by then most people get comfortable with a block, in my opinion.
I think, can we just kind of maybe pivot a little bit towards the meat, so to speak?
I'm a huge fan. Don't you careful. This is a rabbit hole for me.
Okay, we need to talk meat models for a second here, because I actually spend more time than I ever care to admit on gluing cheese sticks in between 2 pieces of steak than I. And there's also moo glue that you can buy on Amazon, which is another deep dark rabbit hole that I went into. Skin on chicken thighs. That's all I'm going to throw out there. They're beautiful, and they actually have these fascial planes that look just like a serratus block, which is unbelievably beautiful. And after gluing and cutting and slicing and way too many trips to the butcher who thinks I'm a psychopath, it's actually been my go-to from now on too. Like the gel phantoms are great for medical students. Tofu is great. We've shoved things through tofu as well, but gluing cheese sticks and whatnot, I agree, it's way too much work. But just chicken thighs, they're cheap. You can throw them away, and that works pretty well. And the students love it.
Yeah, I've landed on skin on bone in chicken breasts. We've used those for a lot of our block training, and then boneless pork ribs are great for serratus blocks, but they don't have any bones. If you use the ones with bones, the layer is too thin and you can't get good visualization of the plane because it's like 1 or 2 millimeters thick. So, you know, yeah, I think the chicken thigh and the chicken breast are both the best options. The nice thing for me is that my chair will pay for all this, which is really nice month to month.
Nice. My chair doesn't care and says, you can go ahead and buy meat and we're not going to help you. So,
Yeah, I mean, I think this is something that if there's a really smart clinician that wants to build something, you know, like that will be useful. And I think you could make a lot of cash on this if you could build something that was reproducible, inexpensive, and nice. It just work. You have to go through and figure out a real process of doing this. There isn't something I've seen that's been great. Rob, have you seen anything else?
So we have this one on the left here. It is not like in terms of fascial spread is just not great, and you don't get great pops on this either. Some people have recommended this Valkyrie one. I think some of the people that do more like the block it like top people recommended this Valkyrie model. And I mean this top right one, it's supposed to be kind of, if it's high pressure, it's supposed to give you feedback of that, and you're supposed to be able to inject around the nerve, and you kind of see a little, kind of some fluid around there. So I mean, I haven't heard anyone personally that is, use these, and I haven't seen these in person, but at least this, some of these simulators, at least you can, you're supposed to be able to actually inject on them. And I think the water is supposed to kind of come out on that. I don't know how quickly that fills up though, because I mean, the simulator we have is just really not there in terms of the moment you inject, it's just kind of not very good anymore. And then there's a whole concept of, I don't know, have any of you played with the needle trainer with intelligent ultrasound yet? I mean, you don't really get that whole fascial spread on that one either, which makes it.
It seems it seems to be a great idea because you can look at the actual anatomy, and it seems like it's. But I didn't love it. I felt like it was. The thought process was great, but it's a fake needle where you're pushing down and it kind of collapses. I don't love it.
Yeah, we demoed it, and we were practicing some brachial plexus stuff, and the person's neck was kind of chewed up after it. You could see all these like holes, and it was almost bleeding, and I don't know. I think like what you said, Arun, I think the idea is great. I just don't think it's quite there yet. But I think in the future it may be pretty interesting to kind of have that virtually simulated needle and the live anatomy, which is kind of nice.
Yeah, I think Shrikar texted me on the side, and I think this is exactly right. It's that fascial plane opening, which people really want, and how to get that's reproducible, that goes away. I mean, it'd be interesting to talk to somebody we're all physicians, we know the endpoint, what we want. Sometimes to go to somebody who has some material engineering background that I know nothing about, that could fix something that would really be very useful for us, and probably we would all buy if we could have like a little model where you just pop through a fascial plane, pop, or one pop, and then you injected fluid tracked in, and it went away into a bucket or whatever, right? You could really do a nice. Trent was saying the Nicora simulator.
Yeah, we have a Nicora fascial IACA trainer that we have. It's kind of the same deal. The anatomy is okay. You can kind of visualize the needle, but you can't inject anything to it. And if you try, you'll destroy the trainer. It explicitly tells you not to do that. We have a couple other trainers in the same way, but we also have a cadaver lab in our sim center because our sim center is crazy. And we've also done some training sessions there. But same thing, like cadavers do not have good fascial planes.
Yeah, we did cadavers for like 5 to 7 years. It was every year in the beginning of the year, we take our interns, and it was a complete cluster. And it seemed great. Did you take David? It was just a bad idea. It seemed like a great idea. I think what people get confused about is I don't think we need the anatomy. We just need the feel of opening fascial planes. And everybody's focused on building an anatomical anatomy, because I mean, I can scan my fellows or they can scan me and we can find the anatomy. I need to get that feel of visualize the needle, get to 2 fascial planes, open the space up.
Harvard does a wet prep on their cadavers. Joe did a cadaver lab over at Brigham that worked quite well, except over time, the fascial layer and the injections kind of wore down. for a specific block, but you do get hydrolyzed sections spread off that type of cadaver model.
Yeah,
we did the same thing, but it was after one use or two uses, it just totally went away. And the data on it, I think, is somebody putting an article maybe online. There's a piece that we read years ago that said it was a great tool. And I just think it was, for the work, it was a lot of work for very little gain, in my opinion. Joe?
Yeah, so the soft prep cadavers, the fascial planes work beautifully. We were able to get probably like 60 people through, doing blocks. We could use both sides of a cadaver. So you could use them about 30 times per site. And as long as you're doing small volume injections, they absorb it pretty quickly with the soft preps.
Yeah, that's been my experience as well. We have the wet prep one. The only problem is the cadavers only last, I think, about 6 to 8 weeks before they decompose. So the turnaround might be problematic.
Yeah, it's not generalizable, right? Then this is it can be trained at very, very few academic centers around the country, and you can't use it at small hospitals where you want to get femoral nerve blocks, and that's how people really need this stuff. So I agree. It was okay. I didn't love it. Plus, I hated being in a cadaver lab all day. I think it was just a pain in the ass. I would love to have a little block that you could just play with and get comfortable with.
We teach some in-plane training with our IV model using the veins as like the nerve, and so we try to show just like the basics of in-plane needling that way. But eventually, the meat model seems to have been a real winner. And I put in a link for like the IV trainers that we did, where we compared a bunch of different simulators, and really found that the meat model was there was just no comparison. The nice thing is that the fascia plane will open up and unzip, but then it'll compress back down because the fluid will leak out onto like the chucks pad that you're on. And so you can do it over and over again. You get that same nice fascial plane opening, so you can really get that experience.
That's been my experience too. Like, we've tried to actually poach cadavers off of other services. We're too poor for cadavers. We can't afford it. We also don't have the fridge or the morgue anywhere near the sim lab. So I've tagged onto the surgical's asset courses where they just basically tear apart the cadaver in one day. And I told them, hey, can we come in beforehand? And it's always a disaster. The cadaver is either too ripe or too frozen. And it's just never a fun experience, and you really don't get a good feel for the anatomy either. Really, our best experiences have been with chunks of chicken.
Nice.
How much, in terms of like simulation is, I mean, here at Ireland, we don't really spend that much of our time building simulation trainers and all that stuff, because I think a lot of the needling, I mean, luckily as more and more of the younger residents are facile with like hand-eye coordination, I feel like the needling itself is not the difficult part, and it's really learning on site. So I mean, I think the model that we use for teaching our residents is really like on our scanning shifts, like it's not, but I mean, I guess like you have to ask what the first thing that you need is it really gonna be needling guidance, like that they need more so, versus like the actual anatomical landmarks that we're talking about, right? So I think it's combining the skill sets, like POCA skill sets that people need for ultrasound guided procedures, right? So the needling guidance. And I think in that sense, then it's really truly maybe the simplified, like really low fidelity models that are just like plain like tofu and stuff work in that sense of getting your needle guidance and understanding that, versus trying to make yeah, that's that kind of understanding which tracks even your resident is used to block today. I think you're a really smart resident to go lateral open back plane and ship it right to the nerve. Yeah. Right. So it's kind of getting in the mind of opening back planes. I think watching videos for that is helpful. Then when we do our teaching in like we do very limited kind of like block teaching, block sessions. I agree. I think you need to have hands-on scanning when you're doing these lectures, because I think if you just do the abstract images and show and don't actually go on the model, we use ourselves like sometimes to show when we do our block days. And I think showing those videos with the fascial plane, even though it doesn't have the tactile function, is a way to kind of circumvent the need for having that type of trainer. But I think it's kind of identifying where on the level of the learners what we're trying to teach. If it's really needle guidance, I think the low fidelity is probably fine for that.
Yeah, and I don't know if y'all do this, but we've also kind of found that it was kind of helpful to, have all these asynchronous sources that y'all mentioned, but then we also kind of like added a little bit of a nerve block thing to like into an orientation. So just given the principles of, this is how you, don't give someone last. This is kind of, how you approach a nerve block, and then kind of just at least kind of get some, practice with like some in-plane needlings, and so many of them have like no experience with it when they show up. So we've kind of found it helpful to kind of have a little mini orientation when they show up, and then kind of like you said, David, it's kind of when the patient arrives in the ED, you have that background, you whip up some quick kind of resources, and you go block and go for it. So kind of do something pretty similar to that too. Does anyone have any other resources that they consistently use for their residents or learners?
No, I do think this is a real issue. I think it would be if we had a simplified, again, sorry, Dan, non-meat, reusable, keep in the docs room, open fascial plane. I think one, it would give them that tactile sensation. Two, would help with needle visualization, and three, would get them to understand that we're not doing nerve blocks, but we're doing, I just sent my fellows this article that is, we're always, the needle tip should be very clear and be away from the nerve. And I think it's a really hard, I mean this, like what David said right here, we just teach our residents because we do blocks every day. It's really hard to do that at another site. We were the only provider that's doing blocks, or one or two of you, and residents who are really eager to learn. So I think it would be a great, somebody could make one of those. I would totally buy it.
Agreed. One of the things that people have started to talk about is, doing some VR. Has anyone done any like virtual reality, nerve block stuff? Because I have not.
There's a company that's doing AR stuff with it. And I've looked at it. I was at, I want to say, I don't know which conference I was at. They had VR and AR, and I tried it, and it was really clunky and uncomfortable. I don't think anybody's done anything well. Has anybody else tried it?
Yes. I said it. Some hospitals, they have like a VR simulator.
Okay. Sounds like no one's really done this, and it also sounds like this is nowhere near ready, but maybe interesting, how that would, happen in the future. But then again, kind of come back to that whole point of kind of that having that tactile feedback of getting into a fascial plane. How are you going to get that on doing, VR? But if there's some kind of combo, maybe it'll be something down the road. But it's interesting that people are trying to do that. I think there's more people kind of in the anesthesia realm kind of dipping into this, but it's interesting. Okay.
Yeah, I'm gonna say that it's, to me, it's low fidelity, and whatever that is, a meat model or a gel block or something. Or sorry, and an image acquisition. If we can get both those three pieces together, I think we can scale this up. So I think it's I think Dan's idea is great to use the meat models. But if we got that, I think we would have a 1-2 punch. And then courses, it'd be great to be able to carry these courses, because I don't want to go the course, I have to buy meatballs from Walgreens or Safeway and bring it in and do it. I mean, it'd be nice if we just had 3 or 4 of these that would just go to courses.
It just doesn't sound like any of them are ready for prime time with the amount of feedback that we want in terms of tactile feedback. So it seems like this combination that Bob's talking about of, you have the pre-course material, you have the hands-on needling, but you also have the hands-on scanning of real patients to identify the anatomy. Like, hey, I'm going to go right here, like Arun, like you said, I'm going to put the needle here. Then you do it on the either the gel block or the meat model, and then you can have that like instantaneous kind of verification from the teacher point of view.
I think it's because the companies don't know what we want. I think the companies think we want, I mean, these companies are making nerves and arteries, and we don't want that. We want a fascial plane opener. It sounds terrible, right? So I think that it's like the same way that when ultrasound companies like GE were making shitty systems because they were making better imaging, we wanted ease of use. So I think that what they're doing is what they see as their endpoint. And our endpoint's different. Our endpoint is find out artery vein, but really want something that's going to pop in and open the fascial plane up. And so I think if somebody would go talk to one of these companies, I think there may be some cool design stuff that could happen between one of us and them to make something that, and they'd get design validation from us and build something cool with their materials engineers, and you would have a nice simulated model.
That's so true. I actually did meet with a company probably last week about this VR stuff. The VR stuff wasn't actually interesting for the nerve blocks. What was interesting was kind of the tele-ultrasound component of this. They're not FDA approved yet, but they're going to have a device that plugs into an ultrasound machine that hooks up to the headset. So I can wear a headset, the resident can wear a headset. I cannot be anywhere near them, but I'll be able to see their hand movements through the device and the head movement, and I'll see the ultrasound image on the same screen. And so it's a little bit more advanced than the tele-ultrasound, which will be nice just for like being at home and able to coach people through nerve blocks a little bit more advanced.
That sounds awesome. Make sure if that, I'll connect with you, Andrew, 'cause that'd be good for our international stuff that we do with our teaching abroad.
Sounds good, man.
Yeah, I think this is a real market opportunity to have one of us, not me, one of us go in, because I think these companies would love to have somebody to help them build something that was scalable. And I know that Blue Phantom got bought out by CEA, and they're doing a lot of work in this space. So I think it would be something I would think about. And I think the other company, that one out of England, the one that you mentioned, it could be useful too. I can't remember the name of it.
Valkyrie?
Yeah. I think both of them will be interested to have clinical leads, because one of the companies was talking to me about something else, and it was I don't want to name the company, but I wanted to build a block box that when you go to the bedside with a needle, it would come with everything built in, and they were really reticent. And then they said they found somebody else who wanted to do it, and it was somebody I'd never heard of, who probably doesn't know the space very well. It was Pajang, but the other company also is thinking of building a block box for both ED and for anesthesia. If they're going to come downstairs to grab a box and go downstairs, because the anesthesiologist comes downstairs is like, where's this? Where's this? Where's this? The nice thing was a box they put on their arm, came downstairs, and you can see how that could be really useful for everybody.
Nice. Well, I think we kind of hit our half-hour mark. Anyone else want to have any other last minute comments or thoughts? But I think, like Arun said, I mean, getting that, that ultimate fascial spread stimulator is kind of the golden ticket here. So cool.
They don't realize that. They think we're trying to hit the nerve, and none of us want to teach our residents how to hit the nerve. But they keep on building nerve simulators where you hit the nerve and you can't put fluid in, which is.
All right.
We could do a couple quick announcements. So I just put the link for the future sessions in the listserv. So if anyone comes to you and says like, hey, what's that blockheads thing you're involved with? Just add them to the listserv, and then we'll get them involved that way. And then Arun, did you want to talk about ASAP at all?
Yeah, I guess hopefully everybody can be, most of them can be at SCUF or ASAP. So hopefully we're going to see everybody at ASAP. If everybody's interested, we're making blockhead t-shirts. Just email me with your size, and we're going to put a bunch together. Kind of be really incognito, so people don't realize what the hell it is. And hopefully they'll be like, what the hell is that stupid? It's the image of Dan in the background. with it says blockheads. It'll be really small, inconspicuous, completely kind of under the radar. No logo, no like telling people what it is. So if you're interested, get a hold of me, tell me your shirt size, male, female, genderless, whatever you want to do. I'm okay with.
Yeah, you can put your shirt size details next to the listserv, next to your email. Any other business from anybody? Great. All right, guys. Well, thank you very much, everyone. We'll get the recording out to everybody. We'll